All right, so I've got a case we're going to talk about. It's back pain, and if you read the top, you kind of gave it away. I was trying to hide it. But spine rounds, this is me. So jump right in. So a lady came in named Maggie. It's not her real name. She believed that she was working nonstop delivering mail in Park City for years, and it was so bad on her body that what she's experiencing now was because she was a mail carrier for 10 years. Because she took some time off, did some schooling, started working again, and just so much pain. She states that her ribs started to hurt in November. She had pain that kind of moved around, but really in her back. Her back was really what brought her into my clinic. Actually brought her into a chiropractor's clinic. Left low back, side and hip, twinge in her ribs on the right, but just kind of radiated. Low back, hip. She doesn't recall any injury. No real straight back pain. Never really had back pain. Never needed shots or anything. Mostly central in her back. Worse, depends on the day it is. Pinching, biting pain, certain positions, constant dull ache. No radicular pain. No loss of bowel or bladder control. No seizures, nothing else that would be worrisome. Coughing or sneezing, getting out of bed, positive, oh, my back pain's way worse. She found that alternating heat and ice has been helpful at times. At best, her low back and hip is at 6, at worst at 9. So she's sitting in a lot of pain. That's why the chiropractor's like, I don't think I'm gonna help this. We need a bigger gun here. So when someone tells you that they cough or they sneeze and it hurts your back, what's the first thing you think of? I'll tell you the first thing I thought of. What's the first thing you think of? Eli. Like a herniated disc, right? Pathognomonic. Like this is a herniated disc until proven otherwise. She saw two chiropractors, Dr. Campbell and a Dr. Johnson. He's the one who sent her to me. No form of physical therapy, but Dr. Johnson does give her exercises. So first strike against her, hadn't done physical therapy yet, right? Mm-hmm. So physical exam, no problems breathing. She was tender in her palpation around L4 where there was tenderness. Positive extension loading, difficulty bending forward, pain in her hips. Her light touch was 2 out of 2 throughout all of her dermatomes. Her strength was good today. Her strength was good. 5 out of 5 throughout right and left. Good reflexes. She had a positive straight leg raise, positive thigh thrust, some hip flexion with resistance, positive favor. So kind of a lot of things. I'm thinking, okay, this sounds like a disc, quacks like a disc, squawks like a disc. Some ischial compression, could be some SI joint in there too. But again, pretty straightforward, or so we thought. So what's our differential? We mentioned a herniated disc. What else? Let's throw everything up there you can think of. Paul, what's something you can throw up there?
You said extension really was painful.
Extension's painful.
I would consider facet disease.
Facet disease, right? Spondylosis. Yeah. She's at the right age. She's probably, got some arthritis. Yes.
The other thing, potentially.
You get one, man. Come on.
Okay, sorry.
All right, what was the other thing?
Well, sometimes if you have them do light extension rather than into pain, if they can do it for a certain amount of time, that will relieve pain, like a McKenzie type exercise.
So you don't put them full extension, kind of light extension.
To tolerance and repetitive.
Interesting.
And if that's sometimes helpful, if it's sometimes a disc bulge, it'll push the nucleus close. If it hasn't completely herniated yet, it'll push it anterior. So you'll get a little bit more room if there's ridiculous.
Okay, all right, so spondylosis, facet disease. All right, what else you got? Whitney, what else you got? Muscle spasm, right? Sure, she was sat for a while doing schoolwork. Now she's going back to work and her muscles aren't ready for that. So muscle spasms, absolutely. Mark, what do you think? SI joint, right? She had positive findings, positive fibers, positive thigh thrust, 3 out of 5 at least, could qualify for at least an injection, if not good physical therapy. What else? Nichols.
Like spondylolisthesis, maybe?
Spondylolisthesis, right? So 10 points to Gryffindor for saying a hard word. Right? Is there some shifting, right? Absolutely, spondylolisthesis, which I think is a word they just made up. They're like, let's just think of a really hard word. What else? There's a lot of other stuff on there. What else are we missing, Stratton?
9 out of 10 pain, potential fracture.
Fracture, compression fracture, absolutely. Again, she's the right age. Maybe there's some osteoporosis. you don't need to do much to break something when you have osteoporosis at an older age. So compression fracture is an option. Dr. Steinhaus, what else? What are we missing here? We don't have to miss anything.
DDD, degenerative disc disease.
Just degenerative disease, not just a hernia disc, just degeneration, maybe vertebrogenic pain. Like we got some swelling, modic changes, potentially on imaging. Anything else you think of?
How long? Has this been years?
Few months, it got progressively worse fast.
Oh,
Infection,
infection.
right? Could be infection. Could be a tumor.
Any central canal stenosis.
Transitional vertebrae.
Transitional vertebrae. Maybe she's got an L6 in there.
Well, a pseudojoint formation.
Okay. So tell me more about a pseudojoint formation.
It's an incomplete transitional vertebrae.
All right.
So, it's enlargement, contact with the sacrum, and you can get a pseudojoint that forms that can be painful.
So painful, not very stable.
Bertolotti's syndrome.
Very good. 10 points. What is your house? By you look like a Ravenclaw.
Spinal stenosis.
Stenosis.
She said, she gets worse with flexion, but with the extension part of it, sometimes you have patients that have primarily claudication back. But it didn't sound.
No, stenosis, that's great. I didn't actually write all of them down. I just wanted you guys to tell me. All right, so we got some imaging. Is that helpful? Those who are closer, what are we looking at here? So again, when I talk to my patients, like, oh, here's your vertebrae, here's a disc. It's like a double stuffed Oreo. We got cream on the inside, black on top, black on bottom. This is a healthy disc. And you're going up, like, oh, disc look okay, but what's next to the disc? That doesn't look so good. So we actually see there's some compression fractures, a bunch of them. So this is a T2 image, and this is the STIR image. And the reason we want the STIR image is because it gives us the acuity or subacuity of that fracture. For someone like me who would consider doing a kyphoplasty or putting cement in there, if you see a fracture and you don't see changes on STIR insurance, then you're less likely to want to put cement in because that time frame is gone. It's an old fracture. So when you see this white stuff, well, if you see the swelling and the STIR changes, it tells you this is more acute. So yeah, she's got some compression fractures, which is why she hurts so much. So no major stenosis, a little bit of retropulsion here. Again, multiple levels. They were very nice to point them out to me. The radiologist was very kind. So a little closer look. I don't see any retrolisthesis or spondylolisthesis. I don't see major DDD in here, right? Obviously, the compression fracture's there. This is not a good picture for facets, but I think she does have some arthritis in her facet joints as well. I didn't put that one in there. So we decided to pursue the kyphoplasty after fighting with insurance for a little bit because they wanted a DEXA scan and they wanted some proof that she was osteoporotic or she had done some treatments. So we sent her to Dr. Mangum's office. Yeah, and we kind of started the process, but still wasn't working. So she had one at T11 and at L2. Successful kyphoplasty, post-procedure doing better, able to walk again. One of the visits, again, it took about a month to get approval. She came back because she was in so much pain, she couldn't even walk. She's like, it hurt so bad, I couldn't even walk. We had to wheelchair her out. After kyphoplasty, she's like 50% better. She's able to walk, do some stuff at home. And then a month later, she's like, the pain has come back. It's difficult with ambulation, loss of appetite, unable to go to the bathroom now. So we're like, in my mind, I'm thinking, well, either we missed something, or is the cement not where it's supposed to be, or did another fracture happen? These are all the things I'm thinking about. She's in my office. Or did we miss something entirely? So by July, so this happened April, kypho was in May, we're now in July, now she can't walk, she's got nausea, difficulty with basic activity. Tried to get her DEXA, insurance made it really difficult. She eventually, she kept canceling on you because she was in so much pain she couldn't get out of the house. Finally, July 4th, we sent her to the ER because her daughter's calling, says, we don't know what to do. And we're like, frankly, let's go to the ER. She sounds like she's getting way worse. Let's just get a workup. Multiple myeloma. So it wasn't just a compression fracture osteoporosis, which it may have been, but they found that she had cancer. So.
When if you're doing typical kyphoplasty, there's drug. I used to always send the material off of the flutes, for pathology. And
Never done that.
a couple of times where I'm the one telling them about the malignancy that they have, and I say, it's not supposed to be this way.
Sure. I've never thought about doing that, but I might consider that. Again, we were under the kind of the, again, try not to be blinders, but we're like, oh, she's that age, osteoporosis, like she didn't fall, this is likely. And then when her DEXA came back, she had osteopenia, not osteoporosis. We're like, ooh, there's something else going on. And then they did the workup in the ER and found that she had multiple myeloma. So bone marrow disease, right? Cancer of the bone marrow, plasma cells are getting so active, they're crowding out the good stuff, weakening the bones and causing all sorts of other issues. This lecture is not about that, but more about what happens when you have metastatic spinal cord compression or compression fractures. So I'm going to go kind of fast. I don't want to spend a lot of time on a lot of this, but there's a lot of patients that have it. Most common with people with breast, lung, or prostate will metastasize to the bone. This occurs when a vertebral body will collapse or direct tumor growth causes compression of the spinal cord. It causes cauda equina. She had some of this. She had some retropulsion, but it wasn't bad enough that she couldn't walk. We think that toward the end it was just pain, but this could have been her. This could have been her. She could have, difficulty walking, difficulty going to the bathroom, but thankfully that was not her. So it's an oncological emergency. It's irreversible. If there's paraplegia due to the 70% of patients diagnosed with this have an established diagnosis, 20% presented as a first site of malignancy, 65 years of age, something to think about. So if you have cord compression due to cancer, this was a study, it said median time was 3 to 6 months. If it's a single met, they'll last longer. If it's radiosensitive, obviously, that makes sense. If there's multiple mets, if it's brain or visceral, it's worse. 70% alive at 1 year, 10% alive at 18 months. So not great statistics. I'm gonna punch through this. So 1 year survival rates for patients with spinal cord compression due to this. Multiple myelomas are at the top, 39%. Lymphoma, breast cancer, prostate cancer, lung cancer. Still, it's 1 year survival rate. So it's pretty good survival if they have that. Hematologic spread of the spine causes collapse and compression. This is why we think it happens 8% of the time, and then 50% of the time it's direct tumor. This is why I want to focus on this and this. So it can be a lot of different things, right? They're walking in, we're thinking this is a disc, they're coughing, they're sneezing. The goal of this was just to have this higher on your differential, because you may see someone who has been going to therapy and now I've got new pain in my back that I didn't have before, and they start complaining of these things. Compression fracture and or cancer should be on the list. Things that could be radicular, could be neurogenic. I thought this picture was interesting. 37% of patients with this have radicular pain. 50% didn't, and most had both. So again, weakness of the limbs is the second most common symptom of cord compression. 18% could walk without help at time of diagnosis. Again, cord compression may have been a little easier to diagnose, like, oh, you can't walk, or you've got positive signs like upper motor neuron signs on exam, things that might have triggered, this might be a spinal cord issue, not just a bone issue, which she didn't have. So imaging, which we showed you before, we wanted to do the T2 and then the T1 with stir, tells us the acuity. So CTF planned to have a procedure, consider myelography. If you're doing surgery on a patient who has a compression fracture, pushing on a spinal cord, is there an image you like to have?
I mean, I think the ones that you list on there, T2 is, and then the stir signal.
Yeah.
So, yeah, the stir sequence.
Do you usually get a CT as well?
It's not common to have a compression fracture cause stenosis, though. It's just not that common.
Right.
It'd be more like a burst fracture or some bigger traumatic event.
Sometimes the CT is helpful to know, like whether if it's all soft tissue will respond to radiation, or if you have bone retropulsion or surgery.
That's what you need a CT. I like it. All right, so consider myelography. Not. Skip ahead. Okay, treatment. So what do we do with this? So here's the WHO classification. Tylenol, Motrin obviously wasn't working for her. Moved up to some weeks like tramadol, wasn't working for her. Bumped her up to some oxycodone. 40% of patients are not able to achieve effective pain relief with this paradigm by itself. If you've got compression fracture or you've got cancer, you probably need something bigger, a bigger gun, like a spinal cord stimulator or intrathecal drug delivery system. So in the pain world, 10 years ago, we put a lot of pain pumps in a lot of people with pain, non-cancer. That paradigm has shifted a lot. It's less for pain, a lot for cancer because there's some good data. But I have a lot of patients, I'm accumulating a lot of patients who have pumps as other clinics kind of close down and stop doing it. And they've been on it for 10 years. And they've been on a certain amount of doses. And we get pretty good coverage. Intrathecal drug delivery, we'll talk about in a second. So what's the risk of infection? So with cancer, they studied 131 patients who were given a spinal cord stimulator or intrathecal drug, and there was a 2.8 infection rate after 1 year follow-up, which was similar to the infection rate of someone who has non-cancer. So just because they have cancer doesn't mean they can't have one of these. Infection isn't a huge, barrier. Stimulator. What is a stimulator? This is what it looks like. Stimulator blocks the dorsal column. Actually, I think that's what it looks like inside the body. So what happens is you get signals that come in. They connect to these small c pain fibers. Oh, there it is. Goes down like this and crosses to the other side, and it goes up to the thalamus. So these are your pain fibers. This is what they're doing for all your patients. So what does a stimulator do? You put it on the dorsal aspect of the spinal cord. It puts electricity into the dorsal columns, and it blocks the pain reception from the brain, because these are alpha fibers, they're larger fibers, and the brain notices those and stops noticing those pain fibers. That's how the dorsal column spinal cord stimulator works. Yay, to the thalamus. There's a case report in 2004 that showed that spinal cord stimulator provided effective pain relief for chemo-induced pain in cancer patients. In 2012, another study showed a safe, effective, and convenient treatment for cancer-related low back pain when opiates have been maxed or side effects limiting treatment. All right, so here is a pain pump. I'll pass this around. This is what it looks like. This looks like a hockey puck. It's a small battery-powered pump that's programmable. It sits under the skin with a small catheter tip in the spinal canal. So for someone who has cancer, who is maxed out their opiates, and they're snogged, they can't go to the bathroom because of side effects, or their brain is cloudy, a pump is a good option because it releases a much smaller amount and a tighter space close to the spinal cord, so you don't need higher doses, and so you have less side effects and better pain relief.
Where does it go under the skin? You said this goes under the skin?
So when that's implanted, they usually put it right there, right there. I've seen it in the back, but generally it's in the front, because this is under the skin, and the catheter is tunneled into the spinal intrathecal space. So to get the medication in and out, they have to come in and we put a needle through the skin into that little rubber thing, and we refill it. And so it runs on Bluetooth. They can turn it up. Well, no, they can't. I can change the dose. You can provide them with what's called a PTM, where they can give themselves boluses throughout the day. And so it's an interesting pain relief paradigm, and it releases a low dose that they can give themselves boluses throughout the day. You can put in morphine, fentanyl. You can put in bupivacaine, hydromorphone. You can also put in something called, it's the snail slug. It starts with P. It's on the tip of my tongue. What? Prialt. That's what it is. They found the venom of sea slugs, and they found that it was really good for nerve pain. But it's very expensive, and that's why I don't use it, because I have to buy it. Insurance doesn't recover. So this is a study in 2002. They enrolled 220 patients in a random controlled trial, comprehensive medical management versus intrathecal for these patients. Systemic opioids had serious side effects of sedation, clouded thinking, constipation, or fatigue. This delivers a small dose of opiate directly to the spinal fluid, achieving pain relief with much smaller doses. Again, that's what it kind of looks like. They found that it improved clinical outcomes, reduced pain, relieved common drug toxicities, improved survival in patients with refractory cancer pain. When I did my residency at VCU, they'd done a big study that showed that patients lived longer. It wasn't just survival. They lived 6 months longer if you had a pain pump. It was pretty cool. All right, bisphosphonates. I'm actually going to stop it there, because I don't want to get into all that, because bisphosphonates are used. So, patient with osteoporosis, what's your dose of bisphosphonate?
Good old Fossilmax.
Fossilmax, there you go.
Yeah, 75 milligrams. So, yeah, that's kind of what I use.
And that's what everyone should use, right? So any questions about a pain pump? To get a pain pump, you have to do a trial. And the trial they'd come into my office, I put a needle into the intrathecal space on purpose, and you put in some morphine or some fentanyl, and you watch them for about 30 minutes. And if they get great relief, trial's a success, and you send them to the surgeon. You don't do pain pumps. Dr. Yonamir, do you do pain pumps?
Not that I trained, my chairman's specialty was chronic pain.
Yeah.
So we had a huge number of stimulators and pumps, and
but you don't do those
After I
implants.
spend time with him, that's like, no.
You're like, no, thank you.
Sorry, one of his early patients I remember, the pump, you need to have that out there, and the patients need to feel it. Because somebody woke up after we implanted one, when I was a resident, and immediately screamed, "Get this out of me now," because they had no idea that there'd be something of that size.
Right. So I think this is a 40 ml pump. There's a 20 ml pump, so it's slightly smaller. And a lot of people are worried about their bikini body, and they're like, well, how's this going to look when I put a bathing suit on? You kind of weigh that against, how they feel. Can they even go swimming if you're in pain? But the good news is it's underneath. Again, I have about 20 patients with pumps right now. You've done a lot of pump stuff throughout your career. I'd say more often than not, it's successful and helps a lot of patients. I recently had a patient who put it in, and she's like, this is bigger than I thought it was going to be, and she wanted it out. But yeah, questions, concerns? Joe? Yes. I haven't. Again, I don't currently see a lot of cancer patients who have pumps in them, but when I was in residency and training, and when the Huntsman does it all the time. They put a lot of pumps in their patients. And Chris Warner, who works for Medtronic, he's the one who bought dinner tonight. He had something come up tonight. He's like, tell them the stories of cancer patients, loved ones who bring the controllers back and say, I want someone else to have this. It made such a difference in our life. We want to make sure that someone else gets this so they can also pass it along. And he said that happens more often than not. And so again, for the right population, pain pumps are really good, but it's not for everyone.
Outside of cancer, what other?
So you can do it for chronic pain.
Spasticity. Yeah, what other?
Spasticity. So baclofen. A lot of people with spasticity, spinal cord injuries, severe cerebral palsy, they have baclofen pumps, and helps a ton. In fact, because the oral baclofen, you get a high enough dose, there's a lot of side effects, and so you can do it a pump, and they can relieve a lot of.
Look at a 6-year-old before these big 40-milliliter pumps in them, but they love it because it gives them their freedom back.
They can get dressed without getting spastic, and yeah. So baclofen. Thanks, I totally forgot that. But my mentor did a study on baclofen and morphine for pain, and his study was that morphine treated someone's spasticity. It was a case study. It was very interesting because he was a person, they were going to put baclofen in. They started with the morphine, and the spasticity got better. And so we'll just leave it alone. Fine. There was some crosstalk in the nerves. But anyway, cool. Spinal cord pumps. Da-da-da-da. All right, let me pull up yours.
Yeah.
Cool.
Sir. All right. So we'll do a quick one here too. I always hate to follow Greg because his presentations are so much better and fancier than mine. So, okay. So I just thought I'd bring up a case and then kind of use this as a way to talk about low back pain and treatments for it. So as always, we'll do discussion and all that stuff. So this was a patient I saw. We'll start with this case. It's a 53-year-old female who presented to me with low back and right leg pain, numbness, and weakness. It has progressed over the past 6 months. She notes progressively worsening pain and numbness in her lateral thigh and calf and dorsal foot and toes. She has also weakness in her right foot when she's trying to pick it up. She's tried chiropractic therapy, physical therapy, and injections with only temporary relief. She notes that having a right L5 selective nerve root block was the most effective for her. So we're starting to target kind of that L5 area as being maybe where she's having her pathology. Otherwise, she's healthy and active. Surgically, she's just had a disc replacement in her neck. Otherwise, no other surgeries. On exam, significant for 4 out of 5 weakness in her right tibia and EHL, and she has decreased sensation in her dorsal right foot. Otherwise, she's full motor and full strength. So I just have a couple cuts here. I wanted to show you the kind of a funky view. Not showing up well here, but this is the side view of her X-ray, and you can see she's got some kind of degenerative disc disease going on at L4-5 and L5-S1. You can see osteovite here at L4-5. Not projecting well here, but she has some loss of disc height here at L5-S1, particularly posteriorly. And you can see that on the MRI as well. I'm showing that kind of right sagittal cut of the MRI here. So you can see here the foramen at L5-S1 is really tight compared to the foramen above. So this is her right L5-S1 foramen. So we think she's probably having some right L5 symptoms and back pain from this degenerative disc disease and and foraminal stenosis. So before we get into any surgical treatment, let's talk about non-operative treatment for this kind of patient. So a patient comes in with back pain and right leg symptoms, very classic spine patient that we see all the time. What is our first, let's talk to Eli, what's the first thing you would do with this patient?
From education, probably do some type of like traction modality.
Mm-hmm.
See if they respond to anything like that. And probably thought of like, deciding whether they're an extension bias or a flexion bias. A lot of times they want to just work off from there.
Okay. And how long do you typically work with them until you decide, okay, this isn't, either is working or not working, or?
I think it kind of depends on their activity level before.
Yeah.
But 53, if they're semi-active, I'd probably hope to see some results within like 3 weeks.
Yeah.
Or I see something.
Okay. Okay. And would you say like the majority of the time you start to see some improvement and keep going?
Mm-hmm.
Yeah. Okay. And is there anything that you guys incorporate in as you, like, so you start with the kind of basic stuff, you start with traction, and as, let's say they start to improve, anything in particular that you focus on as they kind of proceed through these steps and their symptoms are improving, or?
I think a lot of what I target is like in some type of consistent cardio.
Mm-hmm.
Get some type of compression, decompression with gait or walking or swimming or something.
Okay.
That'd be my big one.
Cool. Anyone else have anything to add to that? Yeah.
Love someone like that if they're willing. If people have heard me over the years in here beat my drum about pool therapy. But I would put them in a pool in a aqua jogger or have them sit on a pool noodle and do lots of bicycle work, which is doing some exercises with their upper body, and then put the pool noodle underneath their arms, and it's the same concept. It's just I've had so many people just say they just love to hang in the pool and the traction, taking that weight off, and then having them do exercises, walking, high knee walking in the shoulder depth water. You're amazed at how much they can do without pain.
Right.
So I push that whenever I can get anybody to agree to get to the pool.
Do you guys have a pool that you use, or do they have to find a pool?
I
Or
used to.
Yeah.
For a long time. We had, for about 30 years, we had a pool. So
Okay.
but there are so many pools around now.
Yeah.
I just say, where do you live? Oh,
Yeah.
the West Valley Rec Center's got a pool.
Okay.
What about the sports mall?
Too
What about,
cold.
there's
Yeah.
all the Gold's gyms have a pool.
Yeah.
And, again, if they're willing to go, sometimes it takes you 2 months to convince them to try one time.
Mm-hmm.
And then they come back and say, why the hell didn't I listen to you 2 months ago? Because
Yeah.
they do so much better.
Yeah. I couldn't agree more. I hear that all the time. My patients say pool therapy is amazing. And you guys have a pool, right? Yeah, in Marie. Okay. And you guys do too? Yeah. Yeah. Cool.
In Mountain Land, do you guys have access to pools? We use community pools across the valley.
Oh, great.
Our therapist goes and visits each one.
I thought so, yeah.
Cool. Okay, and what else in terms of non-operative? Greg?
Medications.
Yeah. Yeah, what would you start them on usually?
NSAIDs.
Yeah.
Dilaudid, come on.
Yeah.
Heavy duty.
Yeah. You're holding back. You're holding back.
I know lollipop, baby.
Yeah, just start with conservative stuff.
Yeah.
Get the NSAIDs, whatever
Yeah.
they can tolerate, if they can.
Yeah.
Maybe some muscle relaxers help with sleep.
Yeah.
Sleep's a huge component. If I can give them sleep at night, the rest of the day is easier.
Okay. Tell me about your experience with gabapentin, Lyrica, and those types of medications.
So a lot of people give those out like candy too, but I look for neurologic or neurogenic type of pain before I really do it.
Okay.
They use them as mood stabilizers, they use them as all kinds of stuff.
Okay. Do you find patients have any different reactions to Lyrica versus gabapentin?
Patients tend to tolerate Lyrica better than
That's what I found
gabapentin.
too, yeah.
It's easier to titrate a little faster.
Yeah.
No, I see the opposite. I see
But again,
Right.
it happens in both.
Yeah.
If they've got nerve pain and they're in pain and they're depressed, I might try them on Cymbalta,
Okay.
like an antidepressant that also works with nerve pain.
Okay.
But I generally like Lyrica.
Okay.
Yeah.
What's your starting dose for like gabapentin or Lyrica?
I usually do 300
300?
3 times a day, but
Okay.
over 3 weeks, like work up to it
Uh-huh.
and then kind of reassess.
Okay.
Same as Lyrica, like 75
75,
twice a day, but
twice a
like
day. And then go up to 150 or whatever.
multiple.
Yeah. Cool.
The book answers 1,800 milligrams if you look at the.
Yeah.
Again,
to
if sleep's
start
an
there.
issue, then maybe
Yeah.
amitriptyline is something we can use to help them sleep at night, can help with nerve pain, can help with mood. So again, in the spinal cord injured population, that's a great drug because sometimes they have a hard time keeping their bladder, and you benefit from the acetylcholine aspect of it, and so it helps have urinary retention.
Okay.
That's like the magic drug.
Yeah. And then injections. So what would your go-to injection for this be? Do you prefer the epidural, or you prefer like a right interlaminar epidural, or would you prefer a SNRB, or what do you think is the best
So
way to attack
I usually
this?
do like an interlaminar first.
Okay.
Only because if there is like a herniated disc and if that foramen is more narrow,
Yeah.
I'm more likely going to bump an
Yeah.
angry, fat, swollen nerve, and they're not going to like me.
Yeah.
Interlaminar, farther away from the nerve, and I can cover more space
Okay.
and hopefully calm it down. So if I have to go in again, more specific things will calm down a little bit,
Okay.
and then I can get into transforaminal. Or if I can't, either coddle.
Okay. All right.
How far do those coddles go?
Depends on how far I push.
What do you?
Usually about L4, I think. Yeah. So a coddle is where you go to the sacral hiatus and you put a needle in down at the bottom, literally the top of the butt crack, and you put like 10 cc's behind the steroids and you watch on X-ray, just kind of push up. It's great for people who have had a fusion
Yeah.
and you can't get in any other way. I have a great success with that, but usually it's pretty uncomfortable the first time.
Yeah.
Oh, scar tissue you're fighting through.
Okay. Dr. Yanamura, anything to add to the?
Well, I do a lot of
Discussion.
minor injections, and they're all transforaminal. I usually tell the patients, the interlaminars, the problem is kind of flows wherever the least resistance is.
Right.
That's true.
And unfortunately, there's no squeegee inside the spine. that
Right,
should
to
be like-
shove it over to the, yeah.
So I never know what to do with.
I just have them lay on their side after. I say, lay on your right side.
Grab it, pull it over.
But so today I did a transforaminal and it was so tight. Like I could barely get one. I was pushing his my sister's like, I've never seen you use two hands before. I was like, it's not want to go, and it was just so tight, and she was really uncomfortable. I was like, I'm so sorry. You probably need a surgery.
Yeah.
You use contrast all the time.
I always use contrast. Yeah.
Yeah, there's some people that don't, and
They're crazy.
20% of the time I'm in the perfect location and it's going up a vein. So
Yeah.
they say it doesn't help. It's like maybe it didn't go stay in the right place.
Yeah. Right.
Yeah.
Interesting.
Who do you know that's not using contrast? They're just walking and they're waiting for
The
trouble.
guy that was in my office, Zipnik, orthopedic surgeon, he wouldn't typically do that. Talbot, in Park City, it's kind of variable.
So I can understand maybe in an interlaminar because it's loss of resistance. You can see the technique. Like I'm pretty sure I'm in because I had one patient who was allergic to contrast, and so they're like, okay, we're gonna do it this way. And loss of resistance, pretty sure I'm in. Good flow, I assume, because there's no contrast. But I wouldn't do a transforaminal because at L3 there is an artery called the artery of Adamkowitz that sometimes is hanging out there, and if you think you're in the right place, you're in a vessel, and you could cause an infarct.
Yeah.
And so I usually use dexamethasone only at L3 and above, and use the thicker steroids lower because that artery is not below that.
Yeah. Interesting. Cool. So I thought I'd talk a little bit about degenerative disc disease, which we see super commonly, and it's sometimes a hard thing to treat. So once we let's say we fail all non-operative measures, we're going to talk about surgical treatment now. So for us, patient selection for this is key. And patients frequently have varying degrees of psychological distress and mental component to this stuff too, as we all know, because it's so distressing. Good kind of prognostic factors are advanced degenerative disc disease. So again, very severely degenerative disc, and not just say like disc desiccation or loss of fluid in the disc. Single level involvement. So when you see a spine that has really great discs at all levels except for one, then it's most likely that level is causing the pain. Modic changes may or may not be kind of an indicator that this level is maybe perhaps more symptomatic. And then psychological issues obviously have kind of a negative prognostic impact on this. It's something that plagues us all the time because we see, more often than not, we're not seeing an MRI that has perfect disc throughout minus one disc that looks really bad, and then it becomes so clear. Most of the time it's, okay, they have some facet disease multi-level, they have some degenerative disc disease multi-level, and they come in with back pain, and you're like, I don't know that we have a good surgery for this because it's hard for us to predict, which level is causing the problem, and more likely than not, multiple levels are causing, each X percent of the pain. And so it's very hard for us to think about a surgery that would help the majority of these patients. So this was a study looking at 25 randomized controlled trials meeting criteria for patients that got fusion, and they looked at patients that were divided into groups. So spondylolisthesis patients, patients with degenerative disc disease, and more kind of chronic low back pain patients, who are kind of more general multifactorial low back pain patients. And they found that the degenerative disc disease patients had significantly better outcomes than the chronic low back pain patients when you kind of isolated that disc to one level. And then the spondylolisthesis patients also had very good outcomes, not surprisingly. So it's very hard for us as surgeons to think about what to do with these patients with degenerative disc disease kind of from a surgical standpoint, and fusion seems like a big jump. And so they were kind of drawing a distinction between patients with classic identifiable degenerative disc disease versus just having chronic low back pain without these factors. So this again was looking at fusion for chronic low back pain due to degenerative disc disease. They looked at, this is a systematic review, this is Dr. Phillips, who's out of Rush, and a couple of these slides are actually his from Rush. They looked at a total of about 4,000 patients, and they found that patient satisfaction averaged about 73% across studies with good fusion rates. So that's kind of the number that I would quote patients. Like I actually say coin flip, for patients with degenerative disc disease, we're doing a fusion on, we say this is 50-50. So I don't love to do, that kind of surgery with degenerative disc disease. I don't love a 50-50 outcome when you're doing surgery. They saw 73%, so a little bit higher than what I quote patients, but again, a challenging population. So when we're talking about fusion, there has been kind of more recent effort to do this, what's called standalone ALIF. So ALIF is a really common procedure to do. A lot of these patients have disease at L5S1, and so coming anteriorly, so that's the ALIF portion, anterior lumbar interbody fusion, coming anteriorly at L5S1 is a really common thing to do because the vessels have exited out laterally. And so, the traditional approach is to do kind of a front and then, back it up with screws in the back. More commonly with just degenerative disc disease and without any instability, people have been starting to do what's called standalone ALIF, and showing high fusion rates with good lordosis. The thought being that you're not kind of assaulting, as the word used here, the posterior muscles, low complications, and a kind of a fast surgery with quick recovery. So this study was, again, from Dr. Phillips' talk, looking at selective anterior lumbar interbody fusion for low back pain associated with degenerative disc disease compared to patients with the same condition getting non-surgical management. So these are 75 patients with DDD who had failed 6 months of non-op therapy. They underwent 1 or 2 level isolated anterior lumbar interbody fusion without that posterior fusion component. This is compared to 33 patients who continued non-op therapy. And the VAS and the ODI scores improved by about 50% in the surgical arm. And then the non-operative patients were about 15% for the VAS and 0 or 0.8 for the ODI. So significant improvement with surgery in this study. And this is looking at ALIF for 5-1 degenerative disc disease versus isthmus spondylolisthesis. So that's when you have, as we talked about before, slippage of the spine. And they found similar improvements with surgery in the degenerative disc disease group compared to the spondy group. One newer option that I kind of wanted to put out, this is part of why I wanted to talk about this, is disc replacement for degenerative disc disease compared to fusion. And the studies are showing that there's very reasonable outcomes with kind of a narrow set of indications, and that's the key point to highlight here, is that for to be considered for a candidate for disc replacement, it's kind of a narrow set because most of these patients fail this set of indications for a number of reasons. But here's kind of the list. So patients who failed 6 months of conservative therapy, they have isolated disc degeneration on imaging. So no, facet joint disease because we aren't replacing the facet joints. No bony stenosis for these patients. No more than grade 1 listhesis. So grade 1 is kind of 0 to 25% of the vertebral body. No poor bone quality, so osteopenia or osteoporosis, and then no structural abnormality of the vertebra. And they looked at lumbar disc replacement versus fusion. So this is 10-year data for the pro disc versus fusion, and found that the patients had good outcomes that have been sustained out to 10 years compared to the fusion and the disc replacement groups. So this is kind of what it looks like. I was hoping to show, let's see, a little video here. I have no disclosures with regard to ProDisc. I'm just showing their video.
Is that the most used on the market?
It's
now?
probably the most common. There's something there. There's another one that's commonly used in Germany. So the like Mobi is the company that's used, and it's got a slightly different core to it.
Will insurance pay for this?
Insurance pays for this 1 and 2 level in the U.S.
Will they do 2-level now in lumbar?
They will do 2 level. ProDisc is the only one that's approved for the 2 level. Yeah.
Same time 2 level or one?
Same time at the same time. Yeah.
I think the only other one is Activel.
Activel. Yeah. Right. Do they have a 2 level? Yeah. Yeah. Right.
I don't know if they have two.
I think it's a single level. Yeah. Yeah. So I'm just going to show you guys the video to show you kind of what it looks like. Yeah, exactly. Turn the lights down.
Who's running the show?
Beginning with clinical usage in 1990, in over 30 years of use, ProDisc has become
Kind of speed this up. It's a little bit of a marketing situation here, but just to show you what the disc looks like. So this is cobalt chrome, these 2 metal components, and then there's like a polyethylene core, similar to what's been used in hip and knee arthroplasty for a long time, and it's sprayed on the outside with this titanium that binds to the bone.
contacting surfaces to promote bony integration.
We'll kind of go here. So this is how it's put in. So basically, you do your discectomy, and then you make a keel cut, and you can see these keels are what fit and bind to the bone. And then at the end, you kind of slide in the polyethylene.
Technique facilitates end-plate insertion and provides controlled extraction of polyethylene inlay assembly.
Sorry?
How come that doesn't slip out?
Oh, it binds to the. It's clipped into this lower metal component.
The end-plate options guide.
And they have a bunch of different lordotic options compared to for the patient anatomy.
Set it to like a certain angle.
Yeah, so basically, every patient's anatomy is different. I don't know why this is being funky. Oh, sorry, guys. Every patient's anatomy is different. If someone with a high sacral slope, or if they have a really flat sacrum, you basically can dial your lordosis in based on what the patient's anatomy is. So if most of their lordosis is coming from the sacrum, use a higher lordosis implant for the sacral portion and lower for the lumbar. But you add them up basically to 11 or whatever you're looking for. Yeah. So anyway, that's. Interesting.
So are you and or other surgeons leaning more towards this type of procedure versus fusion?
Yeah, so that's a great question. So in patients who are indicated for it, I think it's a very good option. But that's the key, right? So it's very rare that I see a patient, but we do. I've probably done 20 to 30 of them. But I like to be very, cautious about who we do it, and mostly because the revision setting is not good, because you've come through the front, a lot of scar tissue there, really hard to go back in there and revise it to a fusion. That's why we're very narrow in our indications, because we really want it to be the right patient. And you can imagine, again, as we talked about, patients with degenerative disc disease often have other issues going on in their spine, and then it's very hard for us to say, okay, we're nearly sure that all of your symptoms are coming from the disc and not from the facet, or not from another level, or not from your muscles, or whatever,
So I do a lot of diagnostic hip injections for, orthopedic surgeons that are doing labor repairs, hip replacements, stuff like that. Is there a way to do like a diagnostic injection for this to kind of rule in or out of Canada?
It's a good question. So they used to do discograms, and some people still do them.
I do.
Yeah. Yeah. So actually, I want to hear your experience with them.
Yeah. Oh,
Dr.
with
Yamura.
them,
Yeah.
Well, for me, I need to have some confirmation, and then the other is that I like to have more data points before I pull the trigger and somebody needs to have surgery. So I still do discograms and with a control level, even though that can be controversial. And then they have to have the right history. So sitting intolerance, getting better when they're standing, but it's that loading of the disc is what causes the pain.
Right.
And if the discogram matches, then they could be a potential candidate.
Yeah.
I have somebody just recently who has significant back pain, disc-space collapse, but also has a small recurrent disc at that level, so has some minor leg pain. And so the insurance company just said they're denied because they have leg pain. And so, that's how strange things can be, because his major problem is the back pain, but he does have some leg complaints and has just small recurrent disc, but we're fighting that now to see if we can get that through.
Get the through, yeah.
Because he's a pilot and he'd rather not have a fusion, he'd rather have
Yeah.
an artificial disc and be able to get back to things quicker.
Yeah, and I think that makes a lot of sense. I mean, so here we talk about the main benefits are And we talk about this too in the cervical spine, which is why we like disc replacement in the cervical spine over fusion when you can do it, maintaining your motion. And really the key, it's in my opinion less about maintaining motion at that level and more about less transfer of stress to the adjacent levels. So the data with disc replacement in the cervical spine and the lumbar spine shows that there's less adjacent segment disease. So you hear these stories about spine patients who get surgery once and then okay, maybe in 5 years they need another surgery and another surgery and another surgery. And the whole goal of a disc replacement is to avoid that cascade happening. And then patients, when you do a disc replacement, both in the cervical spine and the lumbar spine, the idea is they have quicker return to activity because getting those keels to heal to the bone is much easier than getting a segment to fuse. So we're quicker to return them to things that they were doing before. So indications for me, I think about younger patients, younger than 60, patients who have low back or leg symptoms, primarily low, it tends to be more low back pain, who failed conservative measures, and very clear degenerative disc disease at that single or 1 or 2 level segments. And then contraindications, kind of more absolute contraindications, anyone with osteoporosis, obviously infection, instability, facet joint disease. So I always go to CAT scan to check for their bone quality, but also to look at their facet joints to see how arthritic they are. Obesity, multi-level disease tend to be contraindications. And then more relative contraindications are kind of on that border cusp of the age limit. Prior lumbar surgery, so a lot of people won't think about doing it if you've had a decompression posteriorly because you've messed with the posterior elements. I think it probably depends a little bit on how extensive that posterior surgery was. Patients with chronic pain who have issues related to that, smoking history, and poor physical health tend to be more relative contraindications. So options for this patient, so we kind of continued non-operative measures as we talked about, fusion or doing a disc replacement. At this point, she kind of had felt like she'd failed all the conservative treatments and really wanted to think about doing a disc replacement. And in my opinion, she has multi-level issues. I did check a CAT scan. She has no facet joint disease and really fit the bill with what Dr. Yanamoto was talking about in terms of how her symptoms were presenting, more flexion-based pain and discogenic pain rather than facet joint arthritis. So we ended up doing a disc replacement at 5'1". And she's doing great. I would say this example of one is probably a little bit kind of borderline with where I typically like to do it. She has more arthritis at other levels than I would like to see. But because we could localize her level because of the L5 symptoms, and it wasn't really a disc herniation at L5S1, it was the collapse of the disc causing that foraminal stenosis. So we really felt like getting indirect decompression by opening up that disc space again would open up the space around that nerve, and she's doing great. So
that's cool.
Just a cool thing to talk about.
So would,
Yes.
Would an MRI or would it show that neuroforamen was open in a follow-up scan?
Ideally, that would be the goal. Yeah, if we had to do a follow-up scan at some point, you would see more space for that nerve. Yeah.
So you don't actually get in the foramen from anterior?
Well, you can. No, you can, and you can do a decompression. So when you do these, especially if there's foraminal stenosis, you really want to be able to see the thecal sac. So I take down, just like with the neck, we take down the PLL, and we take down all of the posterior discal structures to make sure we see the nerve structures and that they're free. So, and especially in this kind of a case, most of the time these are done, it's more about degenerative disc disease and less so about any nerve root impingement. But we like to take that down. It gives you, taking down the PLL, often the PLL makes it very tight, and when you take it down, it allows you to open up the space better.
If you do a fusion, you can get indirect decompression. But since there's no longer any motion, even if you have something behind there, you improve the foramen. But if you put in an artificial disc that's moving, and there's still some stenosis there, it can get worse over time.
Yeah.
I have an exact similar thing, L5 radiculopathy, disc space collapse. I have multi-level kind of degenerative disc disease and mild scoliosis. So I opted to have an L5S1 interbody fusion. Got rid of my leg pain, and then standalone. And it took probably about 1.5 years for my fusion to actually really heal.
Wow.
And you're getting a little settling, and I'm thinking, is my leg pain going to come back?
Yeah.
Oh, am I going to need screws in the back? Now I would be thinking of putting an artificial disc, but
Yeah.
like
Well, I
10
think
years ago, most of the guys would say, it
standalone.
doesn't move much at 5'1", so I'd rather just have a fusion.
Yeah. Yeah.
I think differently about that, man.
Yeah.
I was waddling for the first 6 months because I used that small amount of motion.
Yeah.
And once it's gone, it's like, hey, how come I'm not walking normal?
Yeah.
It's
Interesting. That is interesting.
Who's your physical therapist? Who's your physical therapist?
I actually do as well. I was back working.
Oh!
That's Ruth coming
Yeah,
out.
yeah. That's the cool.
Speaking of that, what is it for something like that? What do you recommend?
What do you how do you rehab that?
Oh, rehab. So, I mean, I'll defer to these guys. They know way more than I do about the rehab, but I get them back. I think you definitely can get them back sooner than a fusion. So, with the fusions, like if we did a standalone ALIF, for example, I usually say hold off on formal physical therapy for the first 3-4 weeks, and then you get in. With these, I basically say once you feel ready, I think you can start, and working with someone to, obviously very gradually and things like that. But I think as soon as 1 or 2 weeks after surgery. Do you guys have any recommendations about that, or?
Do you have like a protocol for disc
I don't-
replacement?
I know, other than we just get them back. We basically give them a physical therapy script at the surgery so that they have it. Whereas patients who are getting a fusion, we wait to see them back at 3 weeks after surgery
You take an X-ray to make sure things are fused and.
Yeah, exactly. And we just don't want them to do too much in the first few weeks while things are kind of settling.
But
in.
those you're like,
I mean,
no barrier, no restriction.
I basically think when we leave the OR, that thing is you don't leave the OR unless it's stable in there, and I think you're not. It's different than trying to get somebody to fuse. If it's stable over time, that thing is going to heal in slowly. And
I think the loading actually helps it. So
I agree. Yeah, exactly. Sometimes it's sitting up just a little bit on the end plate when you leave the OR, and the second they stand, it's going to settle right in there. So I agree. Yeah.
Okay, very cool. Any contraindications? So, down the road, they're having a radicular pain for some reason. Would you recommend, how long would you recommend before they get like a transforaminal or a shot if needed? If there's like radiculitis after for whatever reason?
Doesn't matter.
No.
Yeah.
When you take down the ALL and the PLL, that just scars in as far as and then the mechanics of the prosthetic allows for stability in the
Yeah, so in this device is what's called semi-constrained. So it's not, in the cervical spine, there are many more options that are kind of more unconstrained, where there's really not a lot of constraint there. And there's some that are totally constrained, where it really is acting more like a fusion. And this is semi-constrained because that poly is kind of bound to one of the metal end plates. So it does give you some stability more than just, kind of having it totally open with, because the ALL and PLL are gone, but you still have the bony elements and you have this semi-constraint to the device that gives you some of that. But yes, I think, again, I've actually never done a revision on one through the front, so I don't know what it looks like, but I've seen one in the cervical spine, and it does kind of form this like pseudo capsule sometimes over the device. There's just a little scar tissue that forms over it. I don't know how, stable or structurally important it is, but yeah.
I remember talking to a neurosurgeon who did not want to do these because at the time the data was that getting these were eventually getting fusions later because they failed because of so much weight on the lumbar spine. Is there any data on failed disc replacements requiring fusion?
Yes, so the biggest users in the country, there's this guy Todd Landman in LA who uses them a lot.
Todd.
Classic Todd.
God, such classic Todd.
Yeah, Jason Cuellar in Florida is the other one, and they did a study together showing a revision rate of like 1.5% over 10 years, so pretty low.
Oh wow!
But that is the one scary thing about these is revision is kind of a scary thing because most of the time a revision of this is a fusion just posteriorly because you don't want to go back in the front with scar tissue around the vessels and all that stuff. So that's the downside is if you needed a revision or if something failed, it's a tough situation. So you really want to make it right the first time.
When I was at the U, there was a long history of anterior surgery with Hal Dunn, who used to be the chairman of Orthopedics, and so Rod P, all this, we used to all do our own exposures. And so at L5S1, I usually go on the right side. And then that's saving the left side if I need to do anything go higher.
That's smart, yeah.
But now I'm in private practice, I have to have a general surgeon. None of them want to do anything like that.
Yeah.
There's some of them are just not interested in the challenge of doing something different.
Right. It's
So
interesting.
What do you go through? Like, walk us through, like, you move the intestine?
Oh, the approach? Yeah, so more often so they used to go transperitoneal, so they would go through the peritoneum. Now most people are going retroperitoneal, and the main reason for that is to avoid any post-op ileus or injury to the bowel, obviously, that kind of stuff. So they basically make a incision. The most common place to do it is just left paracentrally. It's almost like a fan and steel incision or like a C-section, but just to the left of midline. They basically go through there and go through the rectus, and once you get through the rectus, which is the abdominal muscles, you can see the peritoneum, and they basically just kind of come around it. You pull the intestines across, and then you're down to the spine, and you identify the iliac. So the iliac vessels usually have diverged at L5S1. So usually at L4-5 is where they're bifurcating. So that's why L4-5 tends to be a little bit more challenging. So especially when you're talking about anterior approach, I'm more likely to do a 5-1 than I'm a 4-5 just because it's safer. And you can go higher if you need to. But again, then you're balancing this risk-benefit ratio. So once you get up to L3-4, especially the aorta and the IVC are just right in the center of the spine, and you're retracting on those. So you get really nervous retracting the vein a lot. But at 5-1, the vessels are usually out to the side, so you kind of retract them minimally so that you get a full view of the disc space. But yeah, basically all they do is push the peritoneal sac aside.
It's the med
and you're
student's
down
job.
And yeah, exactly. Hold it aside.
Hold this for an hour.
Exactly. Yeah, hold this. Yeah, don't sweat. Don't cry. Yeah.
I'm dying.
Yeah.
Don't move.
Yeah, it's a
I'm
cool
gonna quiz you
approach.
the whole time.
Yeah. Yeah.
So this is always an anterior approach for the
disc replacement. Yes. Yeah, it is. They're doing some new study on a device that's like a total spine replacement. It seems to me like that would be a very difficult thing to do. Have you heard this, Dr. Yanimer? There's like a three. Yes. Yeah. Cacciatorian's part of the study.
The name of it, but it's paired devices that you have put in from behind.
Yeah.
And to try and get that in consistently and so it's going to move well, I think that's a challenge.
I agree. It's almost like doing a T-lift because they do bilateral approaches through the facet
We'll just have to get him here next time.
Yeah, exactly. We need Dr. K here. He'll tell us because he's in the trial. But here, I think it's called 3-spine.
I think they just finished the trial.
It's this thing. So you basically put 2 of these in. It seems to me like a lot of moving parts that could potentially fail. And then the problem, I always think as a surgeon, like what's your plan B and C? If something fails, you want to know what you're supposed to do. In this situation, seems very, from the outset. But that's what we think about any new technology. So we'll be curious to see how it pans out. But yeah, it's this one. So I always say to patients, like I'm jealous of the hip and the knee doctors because they can just cut a whole joint out and give you a totally new one. In the spine, we don't have that option because if you have facet joint disease, we can't. You
had a choice, man.
Yeah, exactly.
You chose the spine.
I could go back. Cool. All right. Well, that's it. Yeah.
Hey, thank you.
That was great. Appreciate it. Yeah.